patients here. I believe that we can probably use these for most of the domains we've talked about today as far as why do we bother to assess. We can use them from a prognostic standpoint, to evaluate change over time, to help us treat with treatment decisions, and for discharge planning. Most of these we've addressed already, but one thing I want to talk about specifically here are the treatment decisions one. I mentioned earlier when I started clinically, I would get a sum score. Here's the person's NDI score, RMQ score, whatever. Pop it on the chart. Great, next time they come in, they went from a 30 to a 20. Ah, good, we're getting better. All I saw was the number. If you take a look at those scales, and I didn't give you all of the region-specific scales, they're easy to find online. But if you look at the scales, you can actually identify specific items, specific regions that patients may be having problems with. And that might actually help you with your treatment plan. So the patient says, you know, I'm okay with buttoning up my shirt, but I can't reach overhead. Well, that right there probably tells you something about the condition and gives you a little bit of sense of where you might start to focus your goals in your treatment. Okay. So again, I'm going to say, just as I said with those cognitive scales, I'm going to encourage you that if you start to use these scales, and I hope you do, regardless of what scale you use, look at the individual responses of the patient. Don't worry about necessarily the overall score. You can use the overall score if you want maybe to evaluate change, right? So, as we've said there, a simple rule of thumb, 30% of baseline score or 20% of the overall scale score usually is meaningful, okay? You may want to use the aggregate score if you're trying to establish a prognosis. So both the NDI, the Roland-Morris, the DASH, actually I think to a lesser extent, probably have some prognostic utility, but again, it's because you're trying to predict the same outcome. I've said that, I've beat that drum. Discharge planning, you might be able to identify where a patient's reached a satisfactory level of function even despite maybe ongoing pain. And so on some of these scales, a number below a certain threshold would suggest that people are doing okay. But I gotta say, even there, I hope that you wouldn't look at a scale. Here, your neck disability index score is 4 out of 50. Well, Vernon and Meyer have told us that that indicates essentially no disability. You must be fine. Of course, you're asking the patient, are you ready to be discharged? You're not going to go by these scale scores. So the overall sum score really, in my mind, is less useful for the clinician than are the individual responses to each item. How has the person answered an item on reading, on driving, on lifting, on sleeping, all those sorts of things. Because those are giving you clues as to where you need to focus. Same caveats for pain intensity ratings are relevant, of course, here. It's a transaction. Is what they've said, is that good enough for you to treat them? As I mentioned, don't assume your patient is satisfied simply because they score really well on your scale. You know what the LEFS doesn't measure, the lower extremity functional scale doesn't measure long jump skills. Perhaps your patient's a long jumper. You know, so you need to look at the patient individually and see what they do. Most scales skew towards activities of daily living so that you prevent floor effects, but that means they're less relevant for people who are sort of higher level, higher functioning. So keep that in mind as well. So what I'll do here, again, I'm not going to focus on the region-specific scales. I find physios generally are aware of them at least, OTs or any other profession. If you want to find about, I've listed the scales earlier. You're certainly welcome to go and track them down. There's lots of information online. I'm happy to talk about them more offline as well, if you wish. What I want to take our time up with today, for the rest of the time, is to have you walk away with some new scales you probably don't already use, but that I think can provide some really useful information in a really quick way. In your package, so we might as well go to the packages again. If you turn to this section on something like generic function scales, something along those lines, you should find the brief pain inventory in there. if you take a look at that scale, this may be the one scale that you decide to use as your sort of routine clinical tool. It includes a lot of things we've talked about today. You'll see a body diagram right up front. Now again, it's only giving you front or back. Might miss some potentially important things on the sides or on the medial aspects. You'll notice that then there's 4 questions on essentially pain intensity. There are 4 0 to 10 scales. This one gives you a time frame of the last 24 hours, I believe. Yep, at its worst, at its best, on average, I think right now. Okay. Well, there you go. I've already mentioned that it's worth your while to ask questions just like that. So there they are. Now, do you like that anchor of a 10? Pain as bad as you can imagine. Not my favorite, really. But anyway, it's common. Patients seem to sort of have an understanding of what that means. So that gives you your 0 to 10 scales over different time periods. Best, worst, average, and right now. Oftentimes those are, in the research, those are averaged. So they're subbed and divided by 4 to get an average intensity score. Again, I think clinically, look at them individually. If you flip over on the next one, then you should have, I believe it's medications. Yep, so they'll list the medications that they've taken, and then they indicate whether those are actually being effective. This is a simple tool. It's not meant to take a ton of time, so it doesn't ask about each individual medication, how effective it is. You may or may not do anything with that information, but again, it gives you information right away that you're collecting while they're sitting in the waiting room waiting for you, that otherwise you're going to have to collect while they're there with you in the office and you're trying to do some kind of assessment. And then finally, you've got 7 different activities there. And this is an interference subscale. Again, 0 to 10 scales. People are fairly familiar with those. The arguable knock against this would be that you do have items like, say, walking ability that may or may not be relevant to your patient with, a rotator cuff problem or something like that. But at least you can go through. It doesn't take them much time to fill it out. Done. We've actually, in our lab, we've just completed a very large evaluation of this tool using a database of over 5,000 subjects. So it's pretty big, biggest one that's been done yet, actually. And we found that there's 2 subscales within that interference bit. If you really want to look at individual, is this a physical problem or is it more of a motivational or affective problem? You'll see the physical interference are items A, C, and D on there. If you look at them, they certainly make sense on that interference subscale. And then there's an affective interference, items B, E, and G. The sleep item, we encourage you to look at separately and interpret that separately. Sleep seems to be sort of one of those. Sleep is interesting. Sleep is often thrown into these scales. It represents like a third of our lives for most of us. And yet it's usually thrown into these other sort of function level scales, but it doesn't really seem to fit with function. To me, that's important to know, that you might actually want to use a dedicated sleep scale if you really want to follow how well your patient's sleep is improving. And there's one out there, it's called the Pittsburgh Sleep Quality Index, that actually covers everything you could want to cover about sleep, and it's not hugely long. If your patient was really having a sleep problem, I would encourage you to consider measuring that differently, or separately, okay? And you can look at 20% change, probably meaningful. So the brief pain inventory, nice little tool, 2 pages long, gives you a lot of information all at once. Maybe that's the tool you want to use. If we go over the page, you should see another nice little tool. The Brief Illness Perceptions Questionnaire. Now this one may be the tool that you decide to use as your daily driver, your routine use. I quite like this scale. It's based on what's called the illness representations model. This is health representation, that's not right. Illness representations model. Basically, you go through and they answer again. Each of those, there's 9 questions there. They're all scored 0 to 10. So we're going to come once again to this 0 to 10 scale. It keeps coming back. You'll see that it asks about different aspects of this whole experience, right to the how long they think it's going to last, how well do they think treatment's going to benefit them. Now, you get that scale from a patient, and you look at it and it says something like, I don't think treatment's going to benefit me very well, that should immediately tell you something. That might be a pretty good place to start. Then what are you doing here? Can we fix this somehow? You know, that kind of thing. You might need to address that. All right. The neat thing actually about that is if you look at that 10th question, it's what do you think is causing your symptoms? That's such a potentially important question. I think sometimes we often forget to ask is what's the patient's perspective on what's happening with them, on what's causing their symptoms. So this gives them some time. They can write it in. It's amazing. I have to say, we've got probably about 200 responses on this one in a database. It surprises me how many people will say, like, anxiety or stress or depression. Like, they'll actually identify sort of a psychological cause for their symptoms, for their injury, rather than just a purely physical cause. That's great. Clearly, they're receptive to that idea. So that might be someone that you can start to address that with a little bit easier, a little bit earlier on. So here you go. There's another simple little scale that you can use. You can deploy that in your clinic. I don't think anyone's going to find that overly offensive. There's a question on there around emotional, how much it's affected you emotionally. If you need to address that, you can. There's all sorts of things there that you can address. And again, you look at it individually. You don't sum them up.